Let's just start from scratch with your ABCs, because you guys actually did a really nice job in the documentation, because the whole purpose of ATLS and the ABCs of trauma is to just keep everything organized in your mind. Because people will say, oh, nowadays like C comes here and this comes there and this and that. It doesn't matter, because everything's happening like simultaneously. Luckily, we have a big team. Now, the question comes up about, which do you do first, especially for those that are in the field. So obviously, if someone has external hemorrhage, and you can either, one, put your finger on it, which a good common one that we see all the time are fistulas. So that's a very interesting topic, because a patient will have an arteriovenous fistula for dialysis, and they'll present bleeding, like really bleeding. And everyone freaking out doing all sorts of weird shit, when literally, what do you have to do? Put your freaking finger on it, like this. Don't wrap the patient in dressings and towels and stupid shit and put them in the corner. Put your finger on it. If that doesn't work, you need to get control of the inflow and the outflow. And if that doesn't work, you take a big ass suture and you ligate it. So that's just like an example of, yeah, this deviates in the field or in a scenario where you're kind of like the only person and you're dealing with the chaos like single-handedly. But in real life, we have a big team, multiple people, so we're able to go about this. And the reason we have this is so we don't miss those critical things that we can make a quick intervention on. So A is what? Airway. Okay, and then how do I intervene on A? Intubation. Yeah, so endotracheal tube intubation. So that's where I was going to go. Now you have a patient whose jaw's ripped off their face. What do you do? Cricothyroidotomy. So it's ET tube, or we call that a surgical airway, or a cric. Okay. And then A, we also like to think about them having a collar for cervical spine immobilization. So that's also helpful for A. What's B? Breathing. Good. And what do we do to intervene? Chest tube. Yeah. So what do we do in the field to intervene? Needle. So we can do needle decompression. So 4th, 5th intercostal space, mid-axillary line, same spot that you put a thoracostomy tube or a chest tube, which we're going to do in a minute here. Okay. What would be clinical findings of, say, a tension pneumo? I had a guy yesterday with tension pneumo. What would be findings of a tension pneumo?
Absent breath sounds.
Good. So they're absent breath sounds.
You have like a decreased blood pressure if it's bad enough.
Okay, so tension's meaning they're in shock. Which shock is tension pneumo fall into?
Obstructive.
It is an obstructive shock, because there's increased intrathoracic pressures that limits the venous return back to the heart. Obstructive shock. What are other clinical exam findings up top? Here maybe?
Like JVD.
Yeah, so you see some JVD, again, obstructive shock. What about the trachea? Where's that going to head? It's going to move away. What if I have a patient with a large mucus plug?
It'll go towards the...
So that is what we call complete or absorptive atelectasis, and it actually pulls the trachea towards the site of pathology. So on a chest x-ray, if someone's lung is completely whited out, what are basically the two things that it could be?
A mucus plug.
Mucus plug, trachea maybe towards it, versus... Well, so it won't be whited out with a tension pneumo.
Like a hemothorax?
Yeah, like say a large effusion or a massive hemothorax. And then, again, the trachea is going to probably move away. What would be a quick bedside maneuver to see, to differentiate the two?
Like if it's hyperresonant or...
Okay, that's actually, yeah, like clinically, if it was dull to percussion, you would think there's fluid there. So that's a good idea. What's even better than that we have at the bedside typically nowadays that's super useful?
Like an ultrasound?
Yeah, like an ultrasound. So all of a sudden you just slap the ultrasound on. You see a big fluid collection. Mm-hmm. How do you intervene? Chest tube. Or you see the lung tissue. So then you know you need to do what for that big mucus plug? Bronchoscopy to suck out the mucus plug. Good. Okay, that's B. C, you guys handled well. And how do we deliver the blood? Yeah, so the answer is 2 large bore peripheral IVs. What can we do that's even like another step further?
Central line.
Yeah, so central venous catheter. What are the places that we place a central line?
Subclavian.
Okay.
IJ.
Okay.
General jugular.
Uh-huh.
Or femoral.
Good. So fem is kind of like your code line. We don't really want femoral lines because of the infection risk. IJ and subclavian work well too. Fem, though, in the trauma bay, someone's crashing, boom, throw in a femoral line. And then we would typically put in the trauma situation not a triple lumen catheter, but a cordis catheter, short and fat. Okay? If you have a triple lumen, if you had a patient who has a 14 gauge peripheral IV in their left AC, and they have a triple lumen catheter, central line, in their right IJ, and they're bleeding to death, which line would you use?
Probably the central, I would think.
Okay, central, I have a vote for.
I feel like peripheral.
I have a vote for peripheral. Tiebreaker?
I think central.
Uh-oh, so I'm going to go with peripheral. Why is it?
I mean, you don't want to lose.
There's something to do with the fact that it's a smaller vessel and you can keep it open with fluid.
Anybody else?
Resistance?
Now we're talking. So this all boils down to physics, where the resistance in the tubing is inversely proportional to what? Both things, the length and the diameter of it. So those are both down here. I think it's called Laplace's law.
You could say anything and I believe it.
Someone fix it for me. Tell me what it is. Either way, if you increase the length of the tubing, and I'm sorry, diameter's up top. See, I screwed this up. And if you increase the length of the tubing, it's inversely proportional, right? So this is really long and it's very lengthy. So the resistance is much worse in this, okay? This is the central line. So a triple lumen central catheter is actually, if you look at the box, it's 3 lumens and they're all like 18 or 16 gauge, like IV, like lumen, size lumen through them, okay? So what wins for here? Short and fat. So literally, that's why the peripheral IV is a better choice. It's short and it's fat. It's going to literally get the blood in you quicker, okay? So that's based on this little law here, where our length and our diameter and all that's inversely proportional. I think I really butchered this because I think the length, let's start over. I think the length is on top because if I increase the length, I increase the resistance. And I think the diameter is on the bottom because if I increase the diameter and it's squared, I want to say. I think like radius is in it, like you said. I think it's squared because then if I increase the diameter, I should decrease the resistance. Long story short, short and fat. Someone fix my shit there. That's not good. So again, and then the big thing is someone said before about what am I doing here or what am I delivering because of their shock state? What am I giving them? I think we said it.
LR.
Okay, you can start with some crystalloid, but ultimately the bleeding patient you want to give them?
Whole blood.
Yeah, so it's a MTP, and then you can give whole blood. We have it, but it's contraindicated in a woman of childbearing age. So then what does the MTP consist of?
1 to 1 to 1.
Yeah, 1 to 1 to 1.
FFP and
Packed red blood.
Yeah. So packed red blood cells, fresh frozen plasma, and platelets. Good. All right, that beats C up pretty good. D?
disability.
Yeah. What's the quick and dirty?
Pupils and moving extremities.
Yeah, so what's your pupillary exam like, and can you move all 4 extremities? I just eliminated an uncal herniation with a blown pupil because of which cranial nerve?
3.
Cranial nerve 3. You want to be a neurosurgeon, right?
Possible.
Yeah, it's in the cards. So cranial nerve 3, blown pupil, and then they can't move because they have a high cervical spine injury. Okay, so you just eliminate a bad spinal cord injury and a bad brain injury with pupils, and that. Then taking it a step further is, I heard this, the GCS. Okay, what's the worst you get for showing up?
3.
And what's the best?
15.
Good. Okay. E is then Exposure.
And environment.
Yeah, good. Okay. All right, excellent. Good, good, good. So that's going to, again, combat any of the big, nasty, life-threatening things initially. Then the adjuncts to this are
Okay, there's
Burns or
Chest X-ray.
chest x-ray,
Do fast.
fast,
and fracture.
and a pelvis x-ray. What if they have a big, open, nasty pelvis?
You want to repair the.
Raboa.
Could, if they code, yeah.
You do want to repair lax if they're small. They have a big open one though.
No, open pelvis, like open on the x-ray.
pelvic binder.
Pelvic binder, okay? So that's going to be pelvic binder. This is going to be like your chest tube and all that. And then fast is going to determine not only if I have like a tamponade, cardiac tamponade, because we're looking at the heart, but we're looking at the 3 views of the abdomen to see if we have any intra-abdominal process going on as well. So that patient was hemodynamically unstable with a positive fast. Where does she go?
X-lap.
X-lap, to the operating room for an exploratory laparotomy. The clean kill would be taking her to the, where do all trauma patients go? Either 2 places.
The ICU. Take you.
Nope. Where do we go before we go to the ICU?
Like CT scan.
Yeah. So all trauma patients are either going to go to the operating room because they're unstable, or to the CT. Don't take the unstable patient to CT, clean kill. Okay?